Today again we are going to discuss one important topic of respiration, that is pulmonary circulation. So in detail we are going to see what exactly is pulmonary circulation, and before that we are going to see how it is organized. What is the functional organization of this pulmonary circulation? The pulmonary arteries branch like that of airways, so that each airway branch and arterial branch run parallel to each other. So in the functional anatomy of the respiratory system also we have seen that these arteries are very much close to the airways. So that much branching is seen in cases of pulmonary arteries. The pulmonary capillaries are large in diameter and they have multiple anastomosis. This particular arrangement of capillaries is such that each alveolus is surrounded by a capillary basket. So these capillaries will be large in diameter. If you are going to dissect out, you can see in anatomy classes, and they have multiple anastomosis so that a basket-like structure is formed, and each alveolus will be surrounded by this type of capillary basket. A branch of pulmonary artery divides further to form the arterioles, and that term forms the extensive capillary lattice around a single alveolus, which drains into a branch of pulmonary veins. So every alveolus will be having this particular arrangement. The pulmonary blood vessels with blood in them, they constitute about 40% of the total weight of the lungs. So that much amount of vessels, tremendous or extensive network of blood vessels is present in the lungs. So this is how the organization of these pulmonary arteries is there. So this is here the branches are seen and the capillaries, they are surrounding the alveolus such that they are forming extensive anastomosis and giving a basket-like structure. Now, what are these functions of pulmonary circulation? The first is gas exchange. The second, it acts as a filter. Third is it serves a metabolic function. And the fourth is it acts as a blood reservoir. So these are the very important four functions which are performed by these pulmonary circulation. I hope in your cardiovascular lectures also you will be again having an idea regarding the circulations of each different systems. So in that again there will be repetitions of these some points, but as far as respiratory system is concerned, I feel that this is important to discuss here also. So these will be the four important functions. Gas exchange serves as a filter, metabolic functions, and serves as a blood reservoir. Now what are the special features? It is a low pressure system. Uh, on an average, the pulmonary arterial pressure, if you measure, it is around 15 millimeters of mercury. So it is a low pressure. Along with that, it's a low resistance system also. And the pulmonary artery and its branches have thin walls so that they become more compliant. Due to their high compliance, the pulmonary vessels can accommodate a relatively large amount of blood whenever required. So if you remember again the functional anatomy session, I have discussed this particular point, that the circulation is acting as a reservoir. Why? Because these artery and its branches, they have very thin walls and they are more compliant. That means they are more distensible so that they can accommodate a large amount of blood. The arterioles are also thin walled and they contain less smooth muscle. And if there is less smooth muscle, the ability to constrict is less. That is why most of the time they will be seen as dilated. The pulmonary veins are also thin walled and highly compliant. And these are the special features which are not seen in other type of circulation. They are seen only in cases of pulmonary circulation. Low pressure, low resistance, more compliant, ability to constrict is less as there is less smooth muscle in the arterioles, and veins are also thin walled and highly compliant. The capillaries, as we have seen, that they are forming the lattice in the alveolar wall, that is forming a sheet of blood. Thus, the pulmonary capillaries do not form a capillary network. So everywhere in other parts of the body, the capillaries are forming the capillary network. But here, these capillaries, they form a lattice. So they are interconnected so that they will be forming a thin sheet. The walls of the pulmonary capillaries are very thin, and therefore they collapse if the local alveolar pressure is exceeding the capillary pressure. Now this thing you have to remember. As there is a pressure inside the alveoli also and pressure inside the capillaries also, as this capillary membrane is very thin, if the alveolar pressure is increased, these capillaries can collapse. So these important functional points you have to remember. Change in the pulmonary venous and the left atrial pressure is profoundly affecting the gas exchange. A continuous and close column of blood connects the end and the left atrium, the close end and the left atrium, and the wedge pressure is always reflecting the left atrial pressure. So if these are affecting the gas exchange, because very easily they can collapse. And if you want to measure the left atrial pressure, you can see the reflection of wedge pressure, and that will give the reflection of left atrial pressure. The seventh important point regarding the peculiar features is that this vascular resistance is about 1/10 that of systemic vascular resistance. So it is extremely low resistance, and it is due to thin, short, and wide arterioles, and they have high compliance also. The resting vasoconstrictor tone, which is normally very much in other arterioles, is very low in cases of pulmonary arterioles, or some of the times it is absent, and due to that, most of the pulmonary arterioles are seen to be dilated. The pulmonary vascular resistance is falling with increased pulmonary arterial pressure. So if you increase the arterial pressure, which occurs in cases of increased cardiac output, then at that point the resistance will be decreasing. And this occurs by two mechanisms, either by capillary recruitment or by capillary distension. What is capillary recruitment? It's coming together of many capillaries. So these are recruited, and capillary distension can occur. And due to these two mechanisms, the resistance falls whenever there is increased pulmonary arterial pressure. Now what is this? Why you want to have the low resistance? What is the importance physiological? The most and the important point which you have to remember is due to the low resistance, it decreases the velocity, especially when the flow rate is high. And this provides adequate time for the pulmonary capillary blood to take up the oxygen and dispose the carbon dioxide. So the diffusion and exchange of gases becomes possible due to decrease in the velocity due to the low resistance. The second important point is that it also facilitates the diffusion of gases along the alveolar capillary membrane. So you get increased time, you get increased diffusion also due to decreased resistance. If high capillary pressure is seen, that can cause pulmonary edema, and if the capillary pressure is high, the resistance that will create a pulmonary edema condition, and if there is an edema, it will impair the gas exchange. Say for example, during vigorous exercise, cardiac output generally increases enormously. That increases the blood flow, that will increase the pressure in the pulmonary circulation. But the decrease in the pulmonary vascular resistance decreases the load on the right ventricle and lowers the capillary pressure so that it can prevent the pulmonary edema. So this acts as a safety factor to prevent the pulmonary edema. Again, it is very much important because so many times the complicated serious patients comes to you, and the main reason for this is the pulmonary edema is very commonly seen. So this particular physiological activity of the low resistance is lost in these cases. So normally also during vigorous exercise, these things can happen, but they are prevented due to the low resistance. Coming to the pulmonary blood flow. So these were the peculiarities which we were discussing, and the importance of the low resistance. There is approximately 500 ml of blood present in the pulmonary circulation at any given time, which is around 10% of the total blood volume. The distribution is in the pulmonary artery, it is 150 ml, in the veins it is 270 ml, and in the capillaries it is 80 ml. The distribution of the pulmonary blood flow is like this. In the upright posture, the blood flow increases from apex to the base of the lungs. So this difference, that is the lowest blood flow at the apex and highest blood flow at the base, is due to the effect of gravity. So these physiological factors you have to again remember, because oxygenation will depend on ventilation and the circulation, which are the very important factor to have the proper gas exchange. So in upright position, the blood flow will be less at the apex and highest at the base, and this is due to the effect of gravity. Now, what are the factors which are affecting the pulmonary blood flow? The first one is pulmonary vascular resistance. The second is gravity. The third is alveolar pressure. And the fourth is arterial to venous pressure gradient. So, these are the four important points which can change the pulmonary blood flow. Now, first, one by one, we are going to discuss. So, what is the effect of pulmonary vascular resistance? It is affected in turn by lung volumes, it is affected by hormones, and it is affected by oxygen tension. So, this is the first and the most important point which is affecting the blood flow, and the resistance itself will be affected by lung volumes, hormones, and oxygen tension. Now, how this lung volume changes this resistance? In cases of high lung volumes, the pleural pressure will be more negative. So, increased alveolar diameter at high lung volume decreases the transmural pressure in the vessels. As a result, the alveolar vessels are compressed and pulmonary vascular resistance is increased. So, whenever there is high lung volume, the pleural pressure is more negative, it increases the alveolar diameter, and thus it decreases the transmural pressure, it becomes more thin, and as a result, the alveolar vessels are compressed and vascular resistance is increased. In cases of low lung volumes, the pleural pressure is positive, which compresses the extra alveolar vessels, and this increases the pulmonary vascular resistance. So this also increases the resistance. So the pulmonary vascular resistance also is increased at low lung volumes. So in both the lung volumes, the resistance is more. The pulmonary vascular resistance is lowest at the functional residual capacity. So when at the rest, whatever amount of functional residual capacity is there, the resistance will be lowest, and it increases at both higher lung volumes and the lower lung volumes. So these again things you have to remember, because the lung volumes will be always changing. The second factor which affects the resistance is hormone. Serotonin, norepinephrine, histamine, thromboxane, A2, and leukotrienes are more potent vasoconstrictor, and they will cause the constriction, increasing the vascular resistance, particularly at low lung volumes when the vessels are already compressed. So these hormones will be acting to increase the resistance. Adenosine, acetylcholine, prostacyclin, and isoproterenol, they will relax the smooth muscle or blood vessel, and they will decrease the resistance. So these are the hormones which are decreasing the resistance. The third important factor is oxygen tension. Low oxygen tension increases the vascular resistance by causing the vasoconstriction. So this is a normal natural phenomena which you must have seen or discussed in cases of cardiovascular system sessions. The vascular system part, where you see whenever there is low oxygen tension, the vasoconstriction will be there, and that will be increasing the vascular resistance. So that was the first point which is going to affect the pulmonary blood flow. The second point is gravity. In upright posture, the pulmonary blood flow increases from apex to base of the lungs, as we have already discussed. So with 1 centimeter increase increase in height above the heart, the hydrostatic pressure falls by 0.74. And with 1 centimeter decrease in height below the heart, the pressure increases by 0.74. So that will be the pressure difference which is seen in cases of blood flow. So pressure in the pulmonary artery at the apex, which is about 10 centimeter above, will be 7.4 millimeters of mercury less. As in the apex, due to the effect of gravity, it will be less. So these normal variations again you have to remember. Now the arterial pressure in the lungs at various levels is at the level of the heart it is around 14 millimeters. At the apex of the heart it is around 6.6 millimeters of mercury. At the base of the lungs it is 17.7 millimeters of mercury. So see it is increasing from apex to base. The gravity influences both the arterial and the venous pressures. So as gravity causes change in perfusion from apex to base, physiologically the lung can be divided into 3 zones: upper zone, lower zone and middle zone. So zone 1 is upper zone, zone 2 is middle zone and zone 3 is lower zone, depending on the effect of gravity. The third important factor which affects the pulmonary blood flow is alveolar pressure. So again alveolar pressure will be depending on the lung volume. So alteration in the alveolar pressure due to change in the lung volume changes the pulmonary blood flow, and then it will be affecting the blood flow plus the resistance. The fourth important point is arteriovenous pressure gradient. This difference between the pressure at the arterial and the venous compartment of pulmonary circulation, it actually determines the rate of blood flow that happens everywhere. This arterial venous pressure gradient is always affected again by the alveolar pressure. So all these factors will be interconnected. See, gradient is dependent on alveolar pressure is dependent on the lung volume. The lung volume change is again affecting the resistance. This resistance again will change the pulmonary blood flow. So these are the 4 important points which are going to affect the pulmonary circulation. So how the regulation is done normally in the pulmonary circulation. So pulmonary blood flow is regulated by both factors, active and passive. Active factors are neural factors, hormonal factors and chemical factors. The neural regulation is through generally the pulmonary circulation is innervated with sympathetic nerves. The vessel diameter is virtually unaffected by the autonomic nerves in normal condition. So normally it is innervated by sympathetic nerves, but it is unaffected in normal condition because the resting sympathetic tone of pulmonary circulation is almost absent. So there is no tone of the sympathetic nerves in cases of pulmonary circulation. So in normal condition, the regulation through the neurons or nerves is absent. But this causes mild vasoconstriction, the sympathetics, and the parasympathetic stimulation causes mild vasodilation. Very rarely it is seen, but they can cause these type of reactions like mild vasoconstriction whenever the sympathetics are stimulated, and vasodilatation, which is again very mild in cases of parasympathetic stimulation. The hormonal regulation. The major vasoconstrictors are serotonin, norepinephrine, endothelin, angiotensin, thromboxane A2, and leukotrienes. So whenever these are secreted, they cause vasoconstriction and they will decrease the pulmonary blood flow. The vasodilators are adenosine, acetylcholine, prostacyclin, bradykinin, and nitric oxide. So these are the commonly seen vasodilators. So through these release, it is regulated. The chemical regulation, it involves hypoxemia, or it is also known as hypoxia. So whenever there is hypoxia, it causes vasoconstriction of the small arteries, and in contrast, the hypoxia in systemic circulation and other parts, it causes vasodilatation. But here in cases of pulmonary circulation, whenever there is hypoxia, it causes the vasoconstriction. So it is due to directly causing contraction of pulmonary vascular smooth muscles, The mechanism of this is that it inhibits hypoxia, inhibits the potassium channels and depolarizing the muscle cells that will open the voltage gated calcium channels. Influx of these calcium channel will cause the vasoconstriction. So this is the proposed mechanism or probable mechanism why in cases of hypoxia and pulmonary circulation you get vasoconstriction. The hypoxia-induced vasoconstriction is accentuated by high carbon dioxide or low blood pH. So, if hypoxia is along with high carbon dioxide and along with low blood pH, then it is vasoconstriction will be accentuated. The passive factors are cardiac output, gravity, lung volumes. These are the three passive factors which are going to regulate the pulmonary blood. Now, after having the normal physiology of these pulmonary circulation, some applied part I'm going to discuss, and in that, again, very important point is pulmonary edema. It develops when there is excess of free fluid, which is accumulating in the interstitial spaces and the alveolar. And this edema is caused by following mechanisms. So there will be increased capillary hydrostatic pressure, which is the commonest cause of pulmonary edema. So whenever there is capillary hydrostatic pressure is increased, there is pulmonary edema, which is most frequently from an abnormal high pulmonary venous pressure, which is again commonly seen in mitral stenosis or left heart failure. So if you are going to study this all in detail, you can see whenever you are looking at the patient, we are here in physiology, we study differently the cardiovascular system and the respiratory system or any other system, but it is not in cases of patients. Whenever you are going to see a patient, it will be a complete patient, and that complete patient may be having some cardiac problem, and due to cardiac problem, there may be the complaint will be or presenting symptom will be the respiratory system. So that you have to again analyze, diagnose, and then you have to come to an conclusion and give the proper treatment. So in cases of mitral stenosis and left heart failure, there is high pulmonary venous pressure, and this will increase the capillary hydrostatic pressure, again causing pulmonary edema. The effect of pulmonary edema, it will decrease the gas exchange, which is the most harmful effect that results in hypoxemia and hypercapnia, and this obstructs the small airways, which in turn increases the resistance. The lung compliance also decreases in cases of pulmonary edema because there is an interstitial swelling and increased alveolar surface tension. Work of breathing also increased due to decreased compliance and airway obstruction. Now see, remember your previous lectures, each of the physical factor here has been changed, and that will even abnormality leading to pulmonary edema. So for that reason, again I am telling you that if you read the chapters again carefully, most of the times 1 or 2 books are required, and then you can go through these video sessions or any of the video sessions, whatever you are following, and then try to understand the concept and what is the change which is seen. The second change which is seen in pulmonary edema is increased alveolar surface tension. So there is high surface tension which lowers the interstitial hydrostatic pressure, and that will favor the filtration. The decreased surfactant synthesis will increase the surface tension and cause the pulmonary edema, which is same in cases of ARDS. So there will be decreased surfactant synthesis by decreasing the surface tension. And this high surface tension will lower the hydrostatic pressure, causing the filtration and thus favoring the formation of pulmonary edema. Then there may be decreased oncotic pressure. So plasma colloid osmotic pressure decreases in cases of hypoproteinemia, which occurs generally very commonly seen in starvation. Suppose a person is on starvation, the protein content will be less, that is known as hypoproteinemia. And as we know that albumin is the most important protein which is responsible for giving the osmotic pressure. So if it is less, that decreases the plasma colloid osmotic pressure, and that will decrease in oncotic pressure. All of this will cause increased capillary permeability. So that changes in pressure will cause the capillary permeability to increase, and this is the major cause of pulmonary edema. So you know that there is a exchange of fluid exchange of gases, and for maintaining this exchange, the pressure changes are important. If the pressure change is deranged, that will cause abnormal flowing, that will cause abnormal filtration. And if there is increase in capillary permeability, that will cause lead to more amount of accumulation of fluid inside the vessels, and that will cause pulmonary edema. This can occur, capillary permeability can occur in cases of vascular injury, which is seen in oxidant damage, most commonly in oxygen therapy, in ozone toxicity, or there may be due to inflammatory reactions like actions of endotoxins, or it may be seen in neurogenic shock when in cases of head injury. It is a major cause of pulmonary edema. So you have already finished your lecture on shock. So you can again think how these complications are there, and then think how important to know the each and every part system is well. So that can also lead to pulmonary edema. Now, how we can treat this pulmonary edema? The aim of the treatment of pulmonary edema is to reduce the pulmonary capillary hydrostatic pressure. So that should be the aim. If we are going to reduce this pressure, that will relieve the edema. This is achieved either by diuretics, so you give the diuretics that will decrease the blood volume. Secondly, you can give the digitalis that increases the left ventricular function. So that if because it is seen that inability of the left ventricle to pump the blood effectively can produce the pulmonary edema. So if you are giving any drug which increases the left ventricular function, most of the time digitalis is given, so that will relieve the pulmonary edema. Or you can give vasodilators that cause the relaxation of the systemic blood vessels. Now there is very important factor which is known as pulmonary edema safety factor. Now this is again an extra thing. Reports have shown that the pulmonary capillary pressure should rise to a value equal to or more than the colloidosmotic pressure of the plasma inside the pulmonary capillaries before significant pulmonary edema occurs. So what it is said that the pulmonary capillary pressure should rise to a value equal to or more than the colloidosmotic pressure inside the pulmonary capillaries before it is causing significant edema. As in the human being, the body pressure is 25 millimeters of mercury. One can expect that the pulmonary capillary pressure must rise from the normal level of 7 millimeters to more than 25 millimeters to cause the pulmonary edema. So, safety factor against the pulmonary edema to develop is normally, naturally, physiologically is 18 millimeters of mercury. However, fluid accumulation increases rapidly with further increase in capillary pressure. So these things again you have to keep in mind. Yes, of course, there is a safety factor for of 18 millimeters of mercury, but once it has been started to increase, it will increase very rapidly. So it doesn't mean that you are safe now in this particular zone, so you don't have to treat this particular patient very rapidly. It doesn't mean that, but this is the body's safety factor. Now, the second important applied thing which you are going to see, which is related to the pulmonary blood circulation, is drowning. There are two types of drowning: freshwater drowning and saltwater drowning. In freshwater drowning, though aspiration of water occurs into the lungs, death does not occur due to pulmonary edema. Death in drowning is usually due to ventricular fibrillation. So the aspirated water enters the alveoli and from there into the pulmonary capillary blood because of low capillary pressure and high oncotic pressure. So the water will be entering inside. The entry of water into the blood dilutes the plasma and produces an hypotonic environment for red cells. So if there are hypotonic environment, the red cells will be disrupted, and that will cause hemolysis of the RBCs. The hemolysis in turn cause hyperkalemia and hyponatremia. So there will be increase in the potassium, hyperkalemia because release of potassium, and deprival of sodium. So it will be hyponatremia. And this causes the ventricular fibrillation. Again, I am reminding you that in cases of graphs, you must have seen the cardiac muscle properties and what are the effect of ions on that. If you are remembering these particular practical classes, you can apply this particular knowledge whenever there is increase in the potassium and decrease in the oxygen that can lead to ventricular fibrillation. In cases of saltwater drowning, the aspirated water is hypertonic due to high sodium and chloride content of seawater, and this hypertonic fluid in the alveoli will produce pulmonary edema. The cause of death in seawater drowning is asphyxia. Those who are interested in seeing the forensic medicinal toxicology or in searching what are the cause of death, then it will be again very much important to know these factors. So the drowning again will be different. In cases of fresh water, there will be no production of edema, but in cases of salt water, it will be seen that there is pulmonary edema. So I think this is all regarding the pulmonary circulation. In the next session, I'll be dealing with the ventilation perfusion ratio and the different zones and the ratio